Welcome to another episode of My Weird Prompts, an AI-generated podcast featuring the random prompts of Daniel Rosehill as answered by a revolving cast of friendly AI characters. Join us for deep dives into AI, technology, and whatever other random thing Daniel finds fascinating today. Subscribe on Spotify or your favorite podcatcher. Now, today's episode.
This episode was generated using artificial intelligence. Please verify facts.
Hi there, Herman and Corin. So one of the most tragic periods of recent medical history, maybe arguably even of human history itself, was the wave of neurosurgery that preceded a firm understanding or a firmer understanding of the actual working of the brain. I'm talking about the lobotomy, one of the darkest terms, I think, that just makes the hair stand up on the backs of most people. And it was brutal, tragic, and sad. And ultimately, the non-science that underpinned the whole wave of operations that were performed was debunked, as far as I understand. But Herman and Corin, you can help me there. How it actually was brought to an end, thankfully, but sadly not before many patients had their lives irreversibly changed through the surgery. The conversation about neurosurgery, I think, often ends, or neuropsychiatric surgery, often ends there, and people assume that it's not something, that it's just a horrible relic of the past. And I thought it was interesting to come across a mention recently that that's not exactly 100% the case. We talked about deep brain stimulation and transmagnetic brain, and we did an episode actually about ECT as well, which are not quite the same thing, but again are things that you might think were things that are relics of the past, but not to state that there's any comparison between the early forms of this treatment and the very precise method in which ECT is delivered today. But I'd like to talk about neurosurgery itself for psychiatric syndromes, and I'm reading from our colleague here in ChatGPT. Ablative psychosurgery, modern lesion procedures. These are still performed, but rarely, and under strict ethical oversight. Unlike crude lobotomy, modern techniques create small, precisely targeted lesions using stereotactic methods. Examples: anterior cingulotomy, capsulotomy, and subcaudate tractotomy. You can tell I would have been a horrible doctor or psychiatrist with my difficulty in pronouncing just those three words. Indications are typically extreme, treatment-resistant OCD, or severe self-injurious behavior. These procedures intentionally create small lesions, but are anatomically precise and based on modern circuit models of disease. That is pretty fascinating, Herman and Corin, to know that in rare situations and in extreme indications, this is still done. I think a lot of people don't know that, and I'd love to learn about this whole topic. When we talk about this, it sounds like microsurgery, and those extreme indications that we mentioned here. And one more thing that I mentioned about stereotactic radiosurgery uses focused radiation, for example, gamma knife, to create a lesion without open surgery. Used in some severe OCD cases, again, highly targeted and regulated. There's also epilepsy-related psychiatric syndromes and neuro-oncological or structural lesion surgery. But I think we should limit our discussion to the purely psychiatric cases, treatment-resistant OCD and the like. How commonly are these surgeries performed nowadays? And what kind of, it must be an extremely rare combination of skills to talk about surgery, neurosurgery, and psychiatry in the rare cases where this does come together. Because I think for all the horror with which the topic of lobotomy is justifiably surrounded, it's worth adding this little footnote to the prologue, mentioning how this technique has been changed radically over the years, and the very narrow context with which it's used today.
You know, Herman, there are certain words in the medical lexicon that just carry this heavy, visceral weight. Like, you hear them, and you immediately think of grainy black and white photos, sterile but terrifying hospital wards, and a kind of desperation that we struggle to imagine today. It is a word that feels like a shadow from a darker age of science.
I know exactly where you are going with this, Corn. You are talking about the lobotomy. It is one of those terms that has transcended medicine to become a cultural shorthand for the loss of self, for a kind of state-sanctioned erasure of the human soul.
Exactly. It is probably one of the most infamous chapters in the history of medicine. But what is fascinating, and what Daniel pointed out in his prompt today, is that while the crude, ice-pick lobotomies of the 1940s are long gone, the idea of neurosurgery for psychiatric conditions actually never went away. It just evolved into something incredibly precise and, frankly, very different. It is a story of how we went from a blunt instrument to a surgical scalpel, and eventually to beams of radiation and sound waves.
Herman Poppleberry at your service, and yes, this is a topic that is both dark and deeply technical. Today's prompt from Daniel is about the history and modern reality of neuropsychiatric surgery. Most people think of it as a relic of the past, something we stopped doing once the first antipsychotic drugs hit the market in the 1950s. But modern ablative procedures like anterior cingulotomy and capsulotomy are still performed today. We are talking about February of 2026, and these procedures are still a vital, if rare, part of the psychiatric toolkit for things like treatment-resistant obsessive-compulsive disorder and severe self-injurious behavior.
It is a wild thought, right? Because we have this collective memory of the lobotomy as this blunt force instrument used to pacify patients in overcrowded asylums. But now we are talking about what Daniel called circuit models of disease. It is not about scrambled brains anymore. It is about fine-tuning a broken signal. It is the difference between hitting a television with a hammer to stop the static and using a soldering iron to fix a specific capacitor on the motherboard.
That is a perfect way to frame it. The shift from the lobotomy to modern psychosurgery is really the shift from a butcher's knife to a sniper's rifle. But to understand how we got to that precision, we really do have to look at the shadows of the past. We have to understand the desperation that led to the lobotomy in the first place. I mean, we are talking about a time when the Nobel Prize in Physiology or Medicine was actually awarded for the development of the lobotomy.
1949, right? Igas Moniz. It is often cited as the most controversial Nobel Prize ever awarded.
Absolutely. And it is easy to look back and judge from our vantage point in 2026, but you have to remember the context of the 1930s and 40s. This was before the discovery of Thorazine in the early 1950s. Psychiatric hospitals were essentially warehouses for the suffering. They were overcrowded, understaffed, and often violent places. There were no effective medications for schizophrenia, severe depression, or mania. Doctors were using things like insulin shock therapy, where they would put patients into a coma, or malaria therapy, where they would intentionally infect patients with malaria to induce a high fever.
It sounds like a horror movie.
It was a desperate era. Moniz, a Portuguese neurologist, was inspired by experiments on chimpanzees. He noticed that removing parts of the frontal lobes made the animals calmer. He translated this to humans, calling it a leucotomy. He would drill holes in the skull and inject alcohol into the white matter, or use a wire loop to sever the connections. He believed that psychiatric symptoms were caused by fixed repetitive neural pathways, and by cutting them, he could reset the brain.
And then you have Walter Freeman, who is usually the villain in this story. He is the one who took Moniz's procedure and turned it into the transorbital lobotomy, the infamous ice pick through the eye socket.
It is gruesome to even describe. Freeman was not a surgeon, he was a neurologist. He wanted a procedure that was fast and didn't require an operating room or a drill. He discovered that he could go through the thin bone at the back of the eye socket with a tool that was literally modeled after an ice pick he found in his kitchen. He would knock the patient out with electroconvulsive therapy, slide the pick in, and wiggle it around to sever the frontal lobe connections.
He was a showman, wasn't he? Almost a missionary for the procedure.
He was. He performed thousands of them. He would travel across the United States in his own vehicle, which the press dubbed the lobotomobile. He would perform these surgeries in hotel rooms or in the back of his van. He believed he was saving people from a lifetime of institutionalization. And in some cases, patients were able to go home, but the lack of precision was the horror. You were basically severing the connections between the prefrontal cortex, which is the seat of our higher reasoning and personality, and the rest of the brain. You might stop the anxiety or the psychosis, but you often took the personality with it.
Right, the classic description was that the patient became a zombie. They were manageable, they were quiet, but the light was gone. They lost their spontaneity, their depth of emotion, their very essence. And that is why, when the first antipsychotic drugs like chlorpromazine came out in the 50s, the lobotomy basically died overnight, or so the general public thought.
Well, it died as a mass market solution. It was no longer the go-to for thousands of people. But the underlying idea that certain psychiatric symptoms are driven by specific malfunctioning neural circuits, that idea stayed alive in the background. As our understanding of brain anatomy improved, and as neuroimaging technology like MRI and CT scans began to emerge later in the century, the surgery changed. We moved away from the front of the brain and started looking deeper into the limbic system, which is the seat of our emotions and our primal drives.
This is where it gets interesting for me, because today, we aren't just cutting random white matter, we are targeting very specific tracks. Daniel mentioned 3 in his prompt: anterior cingulotomy, capsulotomy, and subcaudate tractomy. These sound like something out of a science fiction novel, but they are very real, and they are performed with a level of care that is the polar opposite of Walter Freeman's ice pick.
They are based on what we call the CSTC circuit. That stands for the Cortico-Striato-Thalamo-Cortical circuit. Think of it as a massive loop that connects the cortex, which is the thinking part of the brain, the basal ganglia, which helps regulate movement and habits, and the thalamus, which acts as a relay station. In conditions like obsessive-compulsive disorder, this loop basically gets stuck in a feedback cycle. It is like a record player that keeps skipping on the same scratch, repeating the same intrusive thought or the same urge to perform a ritual over and over again.
So, if you can't fix the scratch with therapy or medication, you basically go in and cut the wire that is feeding the loop.
Precisely. Let's take the anterior cingulotomy. This is probably the most common one performed today. They target the anterior cingulate cortex, which is involved in error detection and emotional response. If you have severe OCD, your brain is constantly screaming that something is wrong even when it isn't. By creating a tiny controlled lesion in that area, you can dampen that false alarm. You aren't removing the person's ability to think, you are just turning down the volume on the brain's internal siren.
When you say tiny and controlled, how are we doing that now? I assume we aren't using ice picks or even traditional scalpels.
Not at all. We use what is called stereotactic surgery. This was the game changer. It involves using a 3-dimensional coordinate system to locate small targets inside the brain. The patient's head is often held in a rigid frame, and we use high-resolution MRI or CT scans to map the brain with sub-millimeter accuracy. We can pinpoint a target the size of a grain of rice deep within the brain without damaging the surrounding tissue.
And how do you actually make the lesion?
There are a few ways. One is a radiofrequency probe. A thin needle is inserted through a small hole in the skull, and the tip is heated up just enough to destroy a small pea-sized amount of tissue. But even more impressively, we have non-invasive methods now. One is the gamma knife.
I've heard of that. That is the one that uses radiation, right? No cutting at all.
Exactly. It uses nearly 200 individual beams of cobalt-60 radiation. Each individual beam is too weak to hurt the brain tissue it passes through, but they all intersect at one single point. At that point, the radiation is intense enough to create a lesion. It is literally bloodless surgery. And even newer than that, which is becoming more common here in 2026, is MR-guided focused ultrasound.
Focused ultrasound? Like an ultrasound for a pregnancy, but stronger?
Similar principle, but much more powerful. It uses over 1,000 ultrasound transducers to focus sound waves on a single point in the brain. The friction of the sound waves creates heat, which creates the lesion. And because it is done inside an MRI machine, the surgeon can see the temperature of the brain tissue in real time. They can make sure they are hitting the exact spot, and only the exact spot. It is the ultimate in precision.
That is incredible, but it still raises the big question. How often is this actually happening? If I go to my doctor and say I'm feeling a bit anxious or I'm having some intrusive thoughts, they aren't going to suggest a cingulotomy.
Oh, absolutely not. These are procedures of absolute last resort. We are talking about patients who have failed every available medication, usually multiple classes of drugs at high doses for long periods. They have failed years of intensive cognitive behavioral therapy, specifically exposure and response prevention. They have often even tried electroconvulsive therapy or transcranial magnetic stimulation. These are people whose lives are completely paralyzed by their symptoms.
Can you give us an example of what that kind of life looks like?
We are talking about someone with OCD who spends 18 hours a day washing their hands until the skin is gone and they are bleeding, or someone who cannot leave their house because they have to check the stove for 10 hours straight. Or in the case of self-injurious behavior, we are talking about patients, often with severe developmental disorders, who will literally blind themselves or cause permanent brain damage by hitting their own heads if they are not physically restrained 24 hours a day. For these people, the surgery isn't a choice between being healthy and being operated on, it is a choice between a life of total agony and a chance at some form of functioning.
So, what are the numbers? Are we talking thousands of people a year?
No, it is much smaller than that. In the United States, it is estimated that only about 15 to 20 of these ablative procedures are performed each year. Globally, it might be a few hundred at most. It is incredibly rare. There are only a handful of centers, like Massachusetts General Hospital in Boston, Butler Hospital in Rhode Island, or certain specialized units in the United Kingdom, Belgium, and China that even have the expertise and the ethical clearance to do it.
That is a staggering difference from the lobotomy era, where we were talking about tens of thousands of people. It shows how much the ethical framework has shifted. Can we talk about that? Because the consent process for something like this must be a nightmare.
It is one of the most rigorous processes in all of medicine. Because you are dealing with psychiatric patients, there is always a question of whether they have the capacity to give informed consent. Can someone with severe, paralyzing OCD truly weigh the risks and benefits? In many jurisdictions, you don't just need the patient and the surgeon to agree. You need a multidisciplinary board.
Like a committee that oversees the decision.
Exactly. It is often called a psychosurgery committee or a clinical review board. It usually includes a neurosurgeon, multiple psychiatrists who are not involved in the patient's care, an ethicist, and sometimes even a layperson or a legal representative. They review the entire history of the patient to ensure that every other option has truly been exhausted. They look at the patient's support system, their quality of life, and their ability to understand the permanence of the procedure. In some places, like the United Kingdom, there is even a second level of oversight from a national body to ensure that no single hospital is being too aggressive.
It is like a checks and balances system for the brain. I think that is what people find so scary about the history of the lobotomy. It was one doctor, Walter Freeman, making the call in the back of a van. Now, it is a whole room of experts trying to talk you out of it, unless it is absolutely necessary.
And that is crucial because these procedures are permanent. Once you lesion that part of the brain, whether it is with a probe, radiation, or ultrasound, it doesn't grow back. That is why there has been a shift lately towards something called deep brain stimulation, or DBS.
Right. We've talked about DBS before in the context of Parkinson's disease. It is more like a pacemaker for the brain, right?
Exactly. Instead of destroying tissue, you implant electrodes that deliver a constant, high-frequency electrical pulse to those same circuits we were talking about. The beauty of DBS is that it is reversible and adjustable. If the patient has side effects, you can turn the voltage down. If it doesn't work, you can turn it off or take the electrodes out. It doesn't leave a permanent hole in the brain.
So, why would anyone choose the permanent lesion over the reversible electrodes?
That is a great question. For some patients with severe OCD, the permanent ablation, like the cingulotomy, actually seems to be more effective, or at least more practical. DBS requires a battery pack implanted in the chest, wires running up the neck, and regular visits to a specialist to adjust the settings. There is a risk of infection, a risk of the wires breaking, and the need for surgery every few years to replace the battery. For a patient who is already struggling with obsessions about contamination or bodily integrity, having hardware inside them can be a nightmare. A one-time non-invasive procedure like gamma knife or focused ultrasound can be much less traumatic in the long run.
That is a fascinating trade-off. The permanence is the risk, but it is also the cure. I want to go back to the 3 procedures Daniel mentioned, because I want to understand the nuance between them. We talked about the cingulotomy. What about the capsulotomy?
So, The anterior capsulotomy targets a part of the brain called the internal capsule. This is a massive highway of white matter fibers that connects the thalamus to the prefrontal cortex. By interrupting this highway, you are basically reducing the emotional intensity of the obsessive thoughts. Imagine the obsession is a car driving on a highway. The cingulotomy tries to fix the driver's reaction to the road, but the capsulotomy just closes the highway. It is often used for patients where the anxiety component of their OCD is the dominant feature. It has a slightly higher success rate than cingulotomy, but also a slightly higher risk of side effects like fatigue or weight gain.
And the third one, the subcaudate tractotomy. That one sounds even more obscure.
It is. It targets the area just below the caudate nucleus, interrupting the connections between the orbital frontal cortex and the limbic system. It was very popular in the United Kingdom for a long time, particularly for treatment-resistant depression. Sometimes surgeons will even do a combination of two of these, which is called a limbic leucotomy. They might do a cingulotomy and a subcaudate tractotomy at the same time to hit multiple points in the circuit.
A limbic leucotomy. It sounds like we are slowly mapping out the geography of suffering in the brain, but I wonder about the side effects. Even with this precision, are we seeing personality changes? Are we seeing that light go out that we talked about with the old lobotomies?
That is the big question, and the data is actually quite heartening. Because we are targeting such small, specific areas, the cognitive side effects are remarkably low. In fact, most studies show that patient scores on cognitive tests and even IQ scores actually go up after the surgery.
Right. They go up? How does that work?
Well, it is not that the surgery makes them smarter in a biological sense. It is that they are no longer spending every waking second trapped in an obsessive loop. If you are spending 16 hours a day counting the tiles on the floor or washing your hands, you can't focus on a memory test or a logic puzzle. Once that burden is lifted, the brain is finally free to think about other things. They can focus, they can engage with the world, they can hold down a job. The personality changes that are reported are usually positive. Patients become less irritable, more social, and more open to new experiences because they aren't in constant mental agony.
That is an amazing point. It is almost like the disease itself was the lobotomy, and the surgery is the liberation. It is the disease that was cutting them off from their true personality. But I don't want to paint too rosy a picture here. These aren't 100% effective, right?
No, they aren't a magic wand. For treatment-resistant OCD, the success rate for a cingulotomy is usually cited around 35 to 50%. For a capsulotomy, it might be closer to 60%. That might sound low compared to, say, a hip replacement, but you have to remember the population. These are people for whom the success rate of everything else was 0%. A 50% chance at a normal life is a miracle when you are starting from total disability.
It really puts the ethical weight of the decision into perspective. If you are a doctor and you have a patient who is suffering that much, doing nothing is also an ethical choice. It is the choice to let them continue to suffer.
Exactly. That is the evolution of the framework. In the 1940s, the ethics were about social control making patients easier for the hospital staff to manage. Today, the ethics are about the individual's right to relief from intractable suffering. We've moved from the macro level of managing populations to the micro level of helping a single human being regain their autonomy.
It's also interesting to think about how our view of the brain has changed. We used to think of it as this mysterious monolithic organ where you just had to cut the right part to fix the behavior. Now we see it as this incredibly complex network of circuits. It's a very engineering-centric view of psychiatry.
It really is. We are moving toward what some call interventional psychiatry. It is the idea that if a circuit is broken, we should fix the circuit directly rather than just bathing the whole brain in chemicals and hoping for the best. Medications are like a shotgun blast. They hit receptors all over the brain and the body, which is why they have so many side effects. Surgery is like a surgical strike. And as our imaging gets better, we might be able to identify exactly which part of the circuit is malfunctioning for a specific patient.
So instead of a standard cingulotomy, it would be a custom lesion designed just for your specific brain architecture.
That is the dream. Precision medicine for the soul. We are already seeing the beginnings of this with tractography, which allows us to see the actual white matter pathways in a living person's brain. We can see exactly where the fibers are and target them with incredible specificity, but we are still a long way from that being a routine thing. Right now, the focus is on refining the targets we have and making sure the ethical guardrails stay strong. The shadow of the lobotomy is long, and it serves as a necessary reminder of what happens when we let enthusiasm outpace evidence and ethics.
I think that is why Daniel's prompt is so important. It forces us to look at the continuum. We can't just say the lobotomy was bad and modern surgery is good and leave it at that. We have to understand the lineage. We have to understand that we are still doing the same thing, which is physically altering the brain to treat the mind, but we are doing it with a level of humility and precision that was completely absent 80 years ago.
Humility is the key word there. Walter Freeman didn't have a drop of humility. He thought he had solved the problem of human misery with a piece of sharpened steel. Modern neurosurgeons who do these procedures are often very quiet about it. They don't seek the spotlight. They know they are working on the very edge of what we understand about consciousness and the self. They know that every time they create a lesion, they are making a permanent change to a human being.
It is a heavy burden to carry. Imagine being the person who has to decide where to place that lesion. You are literally changing the physical substrate of someone's consciousness. You are editing the hardware of their soul.
It is the ultimate responsibility, and that brings us to the practical takeaways for our listeners. Because while most of us will never have to face a choice like this, the existence of these procedures tells us something profound about how we view mental health today.
Right. The first takeaway for me is that we need to stop viewing psychiatric conditions as just character flaws, or purely psychological issues that you can just think your way out of. When you see that a physical intervention in a specific brain circuit can stop a debilitating obsession, it proves that these are biological, structural issues. It is a malfunction of the machine, not a failure of the person.
Exactly. It destigmatizes the condition by grounding it in anatomy. The second takeaway is about the importance of the ethical framework. The reason these surgeries are safe and effective today isn't just because the technology got better, it is because the oversight got better. We learn from the horrors of the past that medical progress without ethical boundaries is dangerous. We need the committees, we need the second opinions, and we need the rigorous consent process to protect the vulnerable.
And the third takeaway is the concept of the last resort. We live in a world where we often want a quick fix, a pill, or a procedure for everything. But these surgeries remind us that some problems are so complex that the solution has to be equally complex and carefully considered. They remind us of the value of the long, hard road of therapy and medication before we ever consider something permanent. Surgery isn't a shortcut. It is the final bridge when all other roads have washed away.
Well said. It is a reminder of the resilience of the human spirit, both in the patients who endure these conditions and the doctors who continue to search for ways to help them, even when the history of their field is so fraught with tragedy. It is a story of redemption, in a way. We are taking a dark tool from our past and refining it into something that can actually bring light back into someone's life.
It really is a journey from darkness into a very focused, very precise kind of light. I'm glad Daniel brought this up because it is a part of the medical world that most of us would prefer to keep in the shadows, but there is so much to learn there about who we are and how we work.
It is a weird prompt for sure, but a deeply human one. It touches on the very core of what it means to be a person and what we are willing to do to preserve that personhood when it is under threat from within.
Well, I think that covers the geography of the limbic system and the history of the ice pick for today. If you've been listening to my weird prompts for a while, and you're enjoying these deep dives into the stranger corners of science and history, we would really appreciate it if you could leave us a review on your podcast app.
It really does help other people find the show, and we love hearing from you. Your feedback helps us decide which weird corners to explore next.
You can find us on Spotify, Apple Podcasts, or wherever you get your audio fix. Our website is myweirdprompts.com, where you can find our full archive of over 800 episodes and a contact form if you want to send us your own weird ideas.
Or just email us at show@myweirdprompts.com. We'd love to hear your thoughts on this one. Have you or someone you know ever looked into these kinds of advanced treatments? It is a conversation worth having.
Thanks for joining us on this exploration of the mind and the machine. I'm Korn.
And I'm Herman Puppleberry.
Until next time, stay curious. Goodbye.
Goodbye.
This episode was generated using Gemini Flash 3. Text-to-speech engine was Chatterbox.
Thanks for listening to another episode of My Weird Prompts, an AI-generated podcast featuring Daniel Rosehill's AI prompts as answered by a revolving cast of friendly AI characters including me, Cornelius the Sloth. Subscribe on Spotify or visit myweirdprompts.com.